Hello, my name is Gus Cairns, and this is the first time I'm doing one of IFARA's slots. Thank you very much to Fred Sheikh and to Mark Hubbard for asking me to do this. And I'm talking today with three experts, especially active in the field of prevention, about the studies that they think have been really pivotal and interesting at the 21st CROI conference here in Boston. So to introduce them, on my right I have Beryl Koblin from the New York Blood Center. Here is Susan Buchbinder, who's from the San Francisco Department of Public Health and the UCSF. And here is Matt Golden from the University of Washington and King County Department of Public Health in Seattle. I think I'll start on my right and ask Beryl to give a few words about what you think have been the really sort of standout issues particularly in the prevention and treatment as prevention area from this conference.
Great, thank you. What I'd like to talk about is how we look at treatment as prevention from a variety of different levels. And I think there have been studies that are presented here today that show that there's an influence of the individual level factors such as age and race ethnicity, where younger individuals and African Americans and Latinos are not getting the same access to care, which would then obviously link them into treatment. And that's just increasing the disparities that's going on in terms of prevention and treatment. And I think we can also look then at the network level, where we've seen studies that came out of the Atlanta cohort with very high incidence rates of HIV infection and the relationship to newly diagnosed sexually transmitted diseases within those networks. And then finally, I think there's a really important aspect of the structural factors. And what are those that play into access to care? We have people who use drugs whose providers may be more reluctant to be starting them on ART, which was, I think, clearly demonstrated in the plenary that was given yesterday. There's issues around incarceration and the need to have post-release transition plans, which was raised in a poster by Meyer. Issues around poverty. Access to health insurance. There was a poster from TU about infrequent engagement in care and how that relates to higher community viral load and transmission potential. So I think these are all the factors at different levels that we need to be thinking about in terms of not only prevention but also treatment.
Yeah, okay. So in a way that's approaching the whole subject from the outside in. You're really interested in the kind of broader drivers of what makes it more difficult for people to access drugs, to remain linked to care, and for their treatment to basically work. Okay, that's great. Perhaps zooming in on a couple of the sort of pivotal studies that kind of illustrated those sort of issues, or which you thought were really important. Susan first.
So I would completely agree with Beryl that we've got this multifactorial set of drivers of the epidemic in the U.S., but also in other parts of the world that are creating these disparities. So globally it's women, and in the United States it's men who have sex with men, and particularly young and black MSM, but also transgender individuals around the world. There was a plenary on injection drug users, which is, I think, an underappreciated and resourced set of research goals.
I think it was the first one ever at CROI.
Yes, and we were very pleased that we had someone also from the East, from Malaysia, talking about the very intense IDU epidemic. So we do need to get, and I guess the context of all of this is we need to be sure that people are on treatment who are infected, and first and foremost for their own care and for their own health. And secondly, to try to prevent onward transmission. So the couple of areas that I thought were really novel and that I've really seen mature are some evaluation of transmission clusters and increasing use of phylogenetics, or the genetic fingerprint of HIV infection in larger studies, looking at what do we understand about who's transmitting to whom, and where might we best intervene with our prevention strategies. So this is really, I've seen this field mature, particularly over the last year, but over the last few years, to really helping us understand where the epidemic is going. We've seen new tools for determining what's the rate of new HIV infections. And the better we can do that in a population, the better we can measure how well we're doing at a population level with HIV infections. And I think Matt has a particularly compelling case in Seattle. They have a very nice poster here showing how what a major impact they're having on the local epidemic by treatment in reducing new infections, in reducing deaths, reducing AIDS diagnoses. And then the third area is really on an individual level. How do you then target prevention strategies? Because that's a big focus of where I'm working. And I think that there's excitement in the PrEP field in particular, pre-exposure prophylaxis, and both with with what we have currently licensed, which is a co-formulation of emtricitabine and tenofovir, which is called Truvada, and has been shown in multiple populations to prevent HIV acquisition if an HIV negative person takes it on a daily basis. And we're moving towards testing injectables so that you wouldn't need to take a daily pill. So that's also quite exciting. One of the questions that arises is, well, if I'm on PrEP or if my partner's on treatment, does that mean perhaps I don't need to use condoms? And I think this is a really difficult and thorny issue for providers to address. Condoms are only partially effective also because they sometimes break or slip off or they get over-reported in use. We still recommend condoms with sex because it's been the cornerstone of HIV prevention. But I think that we do need to layer on top of that other kinds of prevention strategies. And there was a very intriguing study of serodiscordant couples that had, I think, 3 times the amount of data of all of the previous studies combined, looking at if the positive person is suppressed, do they transmit to the negative person? And there were no transmissions in that study to date. The caveat is that these were stable serodiscordant couples with several years of relationship before they got into the study. So they may have already figured out how to avoid infection, but we do think that treatment is going to be a big part of driving down the epidemic, and individuals are going to need to talk with their providers about what their particular risk is. And I guess what I would say is there also has been a big increase in sexually transmitted infections around the world. There are several posters on that. And in the setting of a sexually transmitted infection with a positive partner, I think all bets are off. I don't think anybody's recommending that if the positive partner is suppressed but has a sexually transmitted infection, they may still be shedding virus, they may still be infectious. So I would just make sure that that caveat also gets out there, and that that condoms also protect against other sexually transmitted infections, and neither antiretroviral treatment or PrEP will protect against that.
Okay. So Matt, Susan basically gave you a cue there to talk about your own work, but I think it is it exemplifies what we're talking about. There's been a sort of tremendous mix of kind of really good news and really worrying news in terms of particularly prevention and the epidemiology. This conference ranging from, I think it was the partner study you were talking about, which was the study where there were no transmissions between neither gay or straight couples who were on antiretrovirals. Tremendously good news, and but on the other hand, this study in Atlanta where there were just sky-high rates of HIV incidence among young black gay men, which were exacerbated by lacking health insurance, unemployment, incarceration, so on. Just shows, as you say, the structural problems.
Yes.
So Matt, is there anything else that really stood out for you or which you would like to amplify on those points?
Well, I think clearly the bad news is related to disparities. And the 12% incidence in young gay men in Atlanta certainly stands out. And if the goals of the national strategy are that we want to decrease HIV incidence in the United States, decrease the morbidity and mortality associated with HIV infection by improving treatment and decrease disparities, it's that third objective, which it seems to me is going to be the toughest and where I'm most discouraged, I would say. And I think that plays out both in terms of higher rates of HIV, particularly in African Americans and African American MSM, but also a concern that there are going to be growing regional disparities. So the good news, it seems to me, is that I think our national care cascade is probably a lot better than what we've been saying it's been. And that the low numbers, to some extent, reflect deficiencies in the existing surveillance data. And we saw evidence for that here at the conference in studies which have done case investigations of the people who appear to be out of care. So even looking at a selected population in San Francisco where the people had been in care 9 to 15 months earlier, 41% of those people who they thought were out of care, in fact, had simply moved.
Right.
And that's, or some had died. And that's consistent with data, some of which is published, some of which has not been published, from Seattle, from Portland, and from Alaska.
Yeah. It's interesting that, because speaking as a Brit, we're terribly proud of our care cascade. I think it's like 58% suppressed or something at the moment. But that's probably, so you're saying that maybe because we just have a better national surveillance system where we can follow patients around as they move from
So as you make
place to
some of
place.
those corrections, what you end up seeing is in a city like New York, they're looking at 59% suppression among the people who are diagnosed now. That would end up being about 50% suppression overall among all people if you include the undiagnosed people. In Seattle, we think we're about 69% suppressed, including everybody, including the undiagnosed people.
Yeah, so that's very good. There must be something in the Pacific Northwest air, because that's similar to what Julio Montaner has managed to achieve over the border in British Columbia, at least in terms of reduction in diagnoses and increase of number of people on ART. Anyway, so the partner study has been really difficult to interpret, because I think a lot of people in the community are sort of taking it in different ways. Some people are saying, look, there's no transmission. Other people are saying, oh yeah, but there's all these cautions and caveats. So I don't know if any of you is a statistician here. But how do you interpret a study where there may be, the lower bound of the confidence interval is that there may be 0 chance of transmission here, but the upper bound is that there may be a 4% chance of transmission from receptive anal sex over the course of a year, which is makes quite a wide difference.
Yes.
What's the kind of the way you would say to a community member who's trying to struggle to understand that?
Well, I think the issue of the confidence intervals is really important because you don't know where in that range the truth lies, and it may be 0 or it may be as high as 4%. And I think the other caveat in is what Susan raised is that these were individuals who were in relatively stable partnerships, and so I think translating that to a new partnership is, I think, probably not the best way to go.
Mm-hmm. Yes.
And I would just say that in virtually all of the studies that have looked at transmission between partners, somewhere between 1/4 and 1/3 of those infections in the negative person are coming from outside of the relationship.
Exactly.
So these were presumably these were all linked transmissions, so we don't know if people are getting infected outside of the partnership.
We know that 1/3 of the gay couples in the partner study there was admitted to having sex outside the relationship, meaning that probably more of them were, and certainly 16% had STIs, which is, as you have remarked, maybe another exacerbating factor.
And the 95% confidence interval is basically, I guess it's exactly what Beryl said. It's somewhere between 0 and 4%. That if you were to repeat this experiment, and because this is just a sample of all of the people who met those criteria, if you were to repeat the experiment 100 times, 95% of the time it would be somewhere between 0 and 4%. So you've got to think about it as it's somewhere between 0 and 4% if you're an unprotected bottom as a negative partner.
I think, though, it is important that this is a positive
Yes.
bit of news,
Yes.
and you don't want to. We don't want to so emphasize the caveats.
It's the best possible, isn't it?
Right.
Yes.
There were no transmissions. So
Yes.
I think that there are two perspectives to the way to think about it. So one is as an individual potentially at risk for HIV infection. I don't think you can look at this and say, I got no problem,
Yeah.
right? If my partner is undetectable, 0 risk to me. I don't think we can say that. From my perspective, though, as somebody who does prevention work and runs a public health HIV/STD control program, I look at this and say, you know, there's going to be substantial protection, even in MSM, which has been the bit of data we haven't had and which is a critical bit of data.
Yeah.
I can't put a precise estimate on it, but it's going to be a lot. And so it really needs to be an impetus for us to do all the
That's
more to
right.
get people diagnosed and to get them on treatment.
Yes,
Good.
completely agree.
We've only got a few minutes left, but you did mention PrEP. And certainly, I was sitting next to someone during the presentation on the Atlanta incidence findings, and they said, "Oh God, put them all on PrEP." So, is PrEP the answer?
I think it's an answer that's really underused. So there was a whole symposium on PrEP and how to roll it out in both developing and developed countries. And I thought it was a really compelling presentation by a young African-American man who is a counselor who works in a study, and then a young African-American man who's on, man whose partner is HIV positive, who's on PrEP. And what we really, and he talked about the process of first learning about PrEP and what encouraged him to take it and how the support around him helped him to continue to take it, but also how challenging it is in some situations. So I think we need to find ways. We've got this we've got two biomedical interventions. They're kind of opposite sides of the same thing. It's treatment for the positives and PrEP for the negatives, and we need to figure out how to mobilize both of those, and particularly to address the disparities.
Yes.
And I think the other issue is that different strategies are going to be important and work well in different times in people's lives.
Yes.
And so there may be a period of time where PrEP is perfect. And then there may be another time due to changing of partners or changing of circumstances that PrEP is no longer the best approach, and maybe condoms maybe then be the best approach. So I think we shouldn't necessarily think about it as this, you know, you go on this particular approach and this is your lifetime, because it will change.
And in terms of just sort of a very practical thing to focus on, particularly because some of the people who I presume are going to be watching this are going to be gay men in the United States. If you've had a bacterial STI in the last year, particularly if you've had syphilis or rectal gonorrhea or chlamydial infection, you really need to think about whether PrEP isn't a good option for you. Because this is a very consistent risk marker for subsequent HIV acquisition. I'm not saying that you need to go on PrEP for every single person, or you need to go on PrEP for the rest of your life, but this is something that needs to be considered, and it's worth a discussion with a medical provider.
Okay, all right. Thanks, guys. That seemed to go by very fast, but thanks for a really interesting discussion about prevention options. And I think, as this conference is showing, there's a lot of possibilities out there, but I think the bottom line is that we need to get some of those possibilities to the folks who need them. Thanks very much.